Hello, this is Dr. Michelle Chung with the Orange County Healthcare Agency, and I'm here today to provide a COVID-19 overview for our Orange County schools. First of all, I'd like to thank you for attending this presentation and for your interest in learning more about COVID-19 to be able to respond to cases at your schools. In addition, I'd like to thank the Orange County Department of Education, in particular Dr. Olmsted, for partnering with us to bring you this training and the one we provided last week. So my objectives today are to first provide a broad overview of COVID-19, including going over the signs and symptoms of the disease, how it's transmitted, and how we test for COVID. Then I'd like to go over some key terms and principles we need to do the COVID-19 case and contact investigations. And these terms include defining the incubation period, infectious period, and isolation and quarantine. So to back up a little bit, I just wanted to say a few things about coronaviruses in general. So coronaviruses have been circulating for a very long time around the world. They are a large family of viruses that cause infection in humans and in a wide variety of animal species. They are host-specific, meaning certain coronaviruses infect just humans and certain coronaviruses infect certain animals. So they're found worldwide, usually in the winter and spring, and the ones that infect humans, they have names that I'm sure you've never heard of, such as 229E, NL63, OC43, and HKU1. So those are names you haven't heard about, but these viruses definitely have been circulating a lot, and they're a very common cause of the common cold. Children often get infected in early childhood, but they can get multiple infections in a lifetime because immunity to these viruses don't last. They generally cause mild to moderate upper respiratory tract illnesses that only last for a short time period, so it's several days, but they can also cause more severe illness, such as pneumonia, and then especially in people with underlying medical conditions, compromised immune systems, or in the elderly. So in the past, there have been other novel coronaviruses that evolved from animals and caused large outbreaks in humans. These include severe acute respiratory syndrome, or SARS, and MERS, Middle East Respiratory Syndrome. So SARS we haven't seen since 2004, but MERS continues to circulate in the Arabian Peninsula. So the novel coronavirus that causes COVID-19 was first reported back in late December 2019. At that time, several health facilities reported clusters of patients with pneumonia of unknown cause that they thought were linked to a seafood and animal market in Wuhan, China. The thought was that there was initially animal to person spread. So from these patients, a new virus isolated, which was very similar to the SARS coronavirus that I mentioned before. And so that's why they called it SARS coronavirus, or SARS-CoV-2. They then named the disease that SARS-CoV-2 causes COVID-19 coronavirus disease 2019. So these infections from SARS-CoV-2 spread person in China and then through travel outside of China. And now, of course, there's sustained ongoing community person-to-person transmission throughout the world. So this is a map of the world showing the daily confirmed new cases, where the darkest brown color is the largest number of daily confirmed cases, with the darkest brown being 100,000 to 200,000 cases. And you can see the US is one of those countries with the largest number of cases daily. So if we focus a little bit more on the United States, this map is of the average daily case rate in the last 7 days. So the darkest blue color now is the highest average daily case rate, with that darkest blue being 93 to 117 average daily cases per 100,000 population in the last 7 days. So you can see California there is that second darkest blue, 75.2 to 88.8 average daily cases per 100,000 in the last 7 days. So in total in the US, we've had over 16 million cases and almost 300,000 deaths as of December 14th. So now looking at California, we've had over 1.5 million cases as of December 14th and over 21,000 deaths. You can see on the graph on the left, we had a peak in the summer starting around July and August, and now since November, we've been seeing a dramatic increase, much larger than we saw in the summer. In the deaths as well, you see that peak in August, and now we're starting to see that increase in deaths in the last couple weeks as well. In the top right corner, there's a map of California in color, and as you know, our counties have been categorized based on color tiers, with purple being the largest number of cases, at the highest case rates, I should say, and the most restrictive tier, and most of California is in the purple tier. And in fact, we do have regional stay-home orders now in all the regions in blue, which of course include Southern California, and that's because of the high case rates and also the low percent of intensive care unit beds that are available, which of course is very concerning. So focusing now on Orange County, this data is from our dashboard that was posted on December 14th. So as of the data posted on December 14th, we have over 105,000 cases with over 3,200 received in one day, almost 1,700 deaths, almost 1,300 cases currently in the hospital, and slightly under 300 cases currently in the intensive care unit with COVID. These graphs of Orange County data show the trends that we're seeing in Orange County. So the top one is testing positivity. So what that is of the tests that are done for COVID, what percent are positive? The bottom graph is the number of patients who are hospitalized with COVID in blue or hospitalized in the intensive care unit with COVID in hot pink. So similar to the other graph I'd shown before, we did see an increase, a peak in July of hospitalizations and ICU intensive care unit admissions. And now again, in the last couple weeks, we have been seeing an increase. So these tables are our schools data. So this is confirmed cases that are posted on our website on Thursdays. So this is last week's data, and it shows we had 810 confirmed cases reported from our schools. And the table on the left breaks it down by student, teacher, and other staff. And the table on the right breaks it down by what category of school. So elementary, middle, high school, combined K through 12, and then college, university, and vocational. So you can see there that the highest numbers of cases are being reported in our elementary, middle schools, and then our high schools there. So as I mentioned, these are confirmed cases, and I'll talk about in the next session the difference between confirmed and probable cases, because the number of cases you're seeing includes both confirmed and probable. So the virus that causes COVID-19 spreads very easily from person to person. It's most commonly spread during close contact, which is within 6 feet. And the reason for this is that it's mainly spread through respiratory droplets. And these respiratory droplets are larger, and so they don't travel very far because they're heavy and drop out of the air. So these respiratory droplets occur when a person with COVID-19 coughs, sneezes, sings, talks, or breathes. So they're expelled from the person who's infected, and then they can be inhaled by someone else, or they can be deposited in the nose or mouth of someone else who's within that 6 feet distance, which is how far approximately these larger respiratory droplets can travel. They can also occur with direct contact, but most of it, again, with people physically near each other within 6 feet. Much less commonly, the COVID-19 virus, SARS-CoV-2, can be spread by airborne transmission. So this airborne transmission, these are much, much smaller little droplets, which can travel further and be dispersed further. And these transmissions that have occurred have been generally within enclosed spaces with inadequate ventilation. But once again, that airborne transmission is much less frequent, and the most common spread seems to be during close contact within 6 feet with the larger respiratory droplets. Transmission can also occur from contact with contaminated surfaces and objects. So what happens with this is someone who's sick or infectious, they cough or sneeze, and then those secretions contaminate a surface, or maybe they touch their nose or mouth, and then with those contaminated hands, touch a surface and contaminate the surface. So once that surface is contaminated, if someone else comes along and touches it, and then touches their eyes, nose, or mouth without washing their hands first, they then can become infected. So this, again, is less common than through that respiratory droplet close contact route. There's also transmission from people to animals, and pets have been shown to be infected with COVID-19, but that's pretty uncommon. And then also rarely from animals to people. It can also spread from asymptomatic people. So that's something that's been talked about a lot because people who are asymptomatic don't know they're infected. So they can be potentially spreading to other people. And this is, again, spreading pretty easily from person to person. So I went over all these modes of transmission to show you the basis for why we recommend certain COVID-19 prevention measures. So physical distancing is important because, as I mentioned before, the respiratory droplets generally don't travel more than the 6 feet. The face covering's important because if someone is wearing a face covering, then they're less likely to be able to breathe in those contaminated respiratory droplets. And then if a case who's infectious is wearing a face covering, again, less likely to be expelling those droplets into the environment. Hand washing or hand hygiene with hand sanitizer to wash the hands before touching your eyes, nose, and mouth in case you did by chance touch a contaminated surface. Avoiding crowded indoor areas and staying home, really, again, emphasizing the physical distancing, not having close contact with other people. And then our routine cleaning and disinfection to clean and disinfect those surfaces so that someone doesn't come along and touch them while they're contaminated and then touch their nose, eyes, and mouth and then get infected that way. So now that we know how COVID is transmitted, let's talk a little bit more about how long it takes from when it's transmitted till you develop symptoms. So that's called the incubation period. So that's the time interval from when someone's exposed to a disease-causing agent until when their symptoms start. So for COVID, the incubation period is thought to be about 2 to 14 days, with the most common being around 5 days after exposure. So putting this on the timeline now, if you get exposed at day 0, then there's your incubation period. So if you're going to develop symptoms, they would occur about 2 to 14 days after that exposure. And again, the most common around day 5. And that's if you're going to develop symptoms. Of course, as I mentioned before, some people never have symptoms. So as far as what symptoms are associated with COVID, so these are pretty non-specific except for the last one. They can be found in many of the respiratory illnesses, respiratory viruses: cough, fever, chills, headache, fatigue, muscle or body aches, shortness of breath or trouble breathing, sore throat, nausea, vomiting, or diarrhea, congestion or runny nose. So those are all common to other respiratory viruses as well. But new loss of taste or smell is something that has been described of interesting association with COVID. So with other respiratory viruses, such as those causing the common cold, you can sometimes have new loss of smell. And generally, that seems to be because there's inflammation in the nose, causing the congestion and obstruction, and also perhaps altering the receptors on the cells in the nose that bind with the odorants, the things that you're smelling there. And so for that reason, when you have a cold or upper respiratory infection, you can sometimes have a transient, short-lasting loss of smell. The loss of taste generally hasn't been associated as much with other respiratory infections. So the interesting thing with COVID is that you can have this new loss of smell and taste without any other respiratory symptoms. So no runny nose, no congestion, no other signs of inflammation in the nose that explain why you were having the new loss of smell. And then also you can have that new loss of taste. So that's something pretty significant to COVID. Luckily, what they found is about 90% of people with COVID who have that new loss of taste or smell, if they have it, they usually get better within 2 weeks. So our symptom decision trees, which hopefully you've seen before because they are very helpful for your schools, they break down the symptoms between low risk and high risk symptoms. So for children, low risk symptoms are ones that are pretty nonspecific. They're general symptoms of illness, including fever, congestion, runny nose, sore throat, headache, nausea, vomiting, diarrhea, fatigue, and muscle or body aches. What's considered the high-risk symptoms that may be more suggestive of COVID are cough, difficulty breathing, and of course, the loss of taste or smell. So with adults, you can have similar symptoms, and they classify the high-risk symptoms as the cough, difficulty breathing, loss of taste or smell, but similar to children, but also they include high-risk symptoms as fever and the fatigue, muscle, or body aches. And the reason for this is adults in general don't have those viral illnesses as often with the high fevers and muscle aches that children get. So I've described the clinical course of COVID from being without any symptoms, asymptomatic, to having mild symptoms, but then you can also have severe illness and death. The complications of COVID include pneumonia, respiratory failure, liver or kidney injury, heart damage, sepsis, which is overwhelming infection, bacterial superinfection, or blood clotting. There's a syndrome that they saw that was associated with COVID that's rather unusual called multisystem inflammatory syndrome in children, or MIS-C, in which there was diffuse inflammation throughout the body, throughout the different organ symptoms, causing pretty severe illness in children. And later they also saw that it happened in adults, and they called that MIS-A, multisystem inflammatory syndrome in adults. So risk factors for severe illness include age-related risk factors as well as underlying medical conditions. In fact, the risk for severe illness increases with age, with the oldest adults having the highest risk. There's also certain underlying medical conditions that seem to be associated with the risk, and these include cancer, chronic kidney, lung, and heart disease, having a weakened immune system, obesity and severe obesity, pregnancy, sickle cell disease, smoking, and type 2 diabetes. In general, children are less affected by COVID, meaning that they have less severe illness, but they can also have serious illness. And then also, children with underlying medical conditions are at increased risks of severe illness. So if we have someone with symptoms of COVID, it's important that we test to see if they really do have COVID, since the symptoms can be rather nonspecific. So there are different kinds of tests available for COVID, and the ones that we want to be using to diagnose active or current infection are the viral tests. So viral tests are done on either swabs of the nasopharynx, nose or throat, or on saliva. So the nasopharynx, a swab of the nasopharynx is when they put a swab into the nose and go way, 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 way back to the pretty much the back of the throat there, where they when they meet that resistance. So those are those swabs, and so the viral tests have to be done on those either nasopharynx, nose or throat, or saliva specimens. If someone tells you they have a positive test from a blood test, that is not the viral test. That's generally an antibody test. And we only want to be using the viral tests for the diagnosis of current or active infection. So the viral tests can be broken down into two categories. The first one is the type that detects viral genetic material. So those are our nucleic acid amplification tests, or NAT tests, which include the polymerase chain reaction, or PCR tests. So these are more sensitive than the other type of viral tests, which are the antigen tests. So the antigen tests detect viral proteins, which are called antigens, and they are less sensitive. So a negative test does not rule out COVID. However, the antigen tests have a faster turnaround time and seem to be more readily available, and that's why it seems like people are doing antigen tests more commonly. However, the NAT or PCR test that detects the viral genetic material is the gold standard, and that is our preferred test. The one downside to those NAT tests are that they can stay positive for months because they just detect the genetic material. So even if the virus is no longer infectious, if there's any genetic material still present, the test will be positive. And they've seen that people can be positive up to about 3 months. So there are combination tests now that test for both COVID and flu, or COVID and other respiratory viruses, sometimes up to 16, 17 different viruses. And that's important because you can have co-infection, meaning that you can be infected with COVID and be infected with flu at the same time. So if you have a positive test, for example, for parainfluenza, you could also have COVID. So it's important that you also do the test for COVID, even if they have another respiratory virus. So I mentioned the blood tests are not to be used for active infection. So these antibody tests that are done from blood, they're also called serology. They may be falsely negative early in infection, so they should not be used for diagnosis of current infection. And the reason for that is when you're infected with a virus, you may not build antibodies to it right away. And that's why when early in infection, when you're having the symptoms, you may not yet have antibodies, so the test may be negative. But even with COVID, even if you're positive on this test, you have to realize that that might be a false positive, meaning that tests may be cross-reacting with other coronaviruses that are circulating, causing upper respiratory infections and colds in the community. So this is why we don't use this to diagnose acute infection or active infection. And really this test, the antibody test, it's unclear what its benefit is because we don't know if it's positive, if that necessarily means there's antibody present that will prevent future infection, meaning that it's not clear if the test will even show immunity. So when we have someone who tests positive on a viral test for COVID, then we need to understand some measures we can take to help prevent transmission in the home as well as in the community. So the first one is isolation. So isolation is when you have someone who's ill, with a communicable disease and potentially infectious, and you want to separate them from other people and restrict their movement so that you don't spread the disease to people who are healthy. So this is done, it can be done in the home for people who aren't that sick, and then for people who are sick enough to be in the hospital, it can be done in the hospital. So again, this is for ill people who are potentially infectious, so it's for our cases. Quarantine, on the other hand, the quarantine is for people who are not yet ill. So these are people who've been exposed to a communicable disease, and we want to separate them and restrict their movement so that in case they become infectious, they won't be around other people and can't transmit the disease to other people. So this is especially important with COVID because people can be asymptomatic even though they're infected, so they won't even know that they're infected. So contacts of known cases could potentially be infectious and going around and infecting other people. That's why we want to quarantine our contacts. Generally, that's done at home. It also can be in other facilities, but most commonly we quarantine people at home. So isolation and quarantine are usually voluntary measures, but they can be mandatory. And our health officer has issued orders that cover isolation and quarantine, and these are available on our website. The most recent version is November 20th, and it's currently under revision with the new CDPH, California Department of Health, and CDC, Centers for Disease Control, quarantine guidance that was just released last week. So when we have someone who's a case of COVID, we would like them to self-isolate at home. So the CDC has this flyer that has 10 things you can do at home with COVID to manage your symptoms. So first of all, most importantly, they need to stay home. So stay home from work and school, stay away from public places. They can monitor their symptoms, and if they get worse, they need to call their healthcare provider. If they do need to see their healthcare provider, they need to tell them ahead of time that they have COVID so that measures can be taken in the office to prevent transmission to other people in the waiting room. They should be covering their coughs and sneezes with a tissue or use the inside of the elbow and then washing their hands frequently so that they don't contaminate surfaces. So I mentioned number one, to stay home, but even within the home, they need to stay away from other people in the home. So as much as possible, stay in a specific room by themselves. And of course, we don't leave young children by themselves, but if they can, keep that 6 feet distance as much as possible. And cases should be wearing a mask, even within the home if they have to be around other people. So it's best if they have their own room, and it's best if they have their own bathroom. If they have to share a bathroom, they should be cleaning and disinfecting it after using it. They should be avoiding sharing personal items. And then, of course, clean any surfaces that are in the areas that other people might be in contact with them. So when they're at home in isolation, there should be no visitors because we don't want to expose other people. And then if they're able to stay in that room by themselves, the best thing is if the food is brought to their door of that room where they are isolating so that they can just open the door, grab the food, and then eat by themselves in the room and not expose other people while they are eating. And then they can leave the dirty dishes outside the door so that they don't have to leave the room. So when we ask our cases to isolate, there's 3 criteria for how long they have to isolate. So our cases with mild to moderate illness, and that is the majority of our cases that are at home, the 3 criteria are they have to isolate for at least 10 days after the symptoms started. So after the symptom onset, and it has to be at least 24 hours after the fever resolved without the use of fever-reducing medications, and the other symptoms such as cough and shortness of breath have to have improved. So you have to have all 3 things. So the minimum would be 10 days since that is one of the criteria. And so a minimum would be 10 days after onset. So a couple other notes. would be, so fever-reducing medications, what are they? Those include anything with acetaminophen, which is Tylenol, ibuprofen, which is Motrin or Advil, or anything with the other nonsteroidal anti-inflammatory drugs such as naproxen and Aleve, and then also aspirin. Those are all fever-reducing medications. And when we say other symptoms have improved, so that's the respiratory symptoms, runny nose, sore throat, cough, shortness of breath. We don't expect that their loss of taste or smell have improved yet because that sometimes takes longer. So we don't have to keep them in isolation until their loss of taste or smell improve. It just needs to be these three criteria, and including a general other symptoms have improved. And then the other thing is to note is that it's improved, not resolved. We don't have to keep them in isolation till their symptoms are completely better. They just need to be a little bit better. So that was for our cases with mild to moderate illness. So our cases with severe or critical illness, those are the ones that had to be hospitalized with pneumonia or hospitalized and needed oxygen. Or people who are severely immunocompromised, those are people who are on chemotherapy for cancer or on other drugs that suppress their immune system. So those people who are have severe or critical illness or who are severely immunocompromised, their duration of isolation goes at least 10 days and up to 20 days after symptoms started. And of course, they still have to meet the criteria that at least 24 hours after fever resolved without using fever-reducing medications and their other symptoms have improved. Realize that most of these cases with severe or critical illness or who are severely immunocompromised have a healthcare provider. So really they should be deciding exactly how long, the 10 up to 20 days, those cases should be isolating, since their healthcare providers will know their history better, their clinical course, and also how severely immunocompromised they really are, based on their medical conditions or the medications they are on. So that was the duration of isolation for people with symptoms. So for our cases who never develop symptoms, they need to self-isolate for at least 10 days after the date that the first positive test specimen was collected. So it's not 10 days after the date you got the result, it's 10 days after the date that specimen was collected. If someone is severely immunocompromised and never develops symptoms but tests positive, they have to self-isolate for at least 10 days and up to 20 days after the date of the first positive viral diagnostic test. If they're initially asymptomatic when they get tested, then they develop symptoms, then you need to extend the isolation based on the symptom-based criteria. So at least 10 days after onset, no fever for 24 hours without fever-reducing medications, and their symptoms in general have to have improved. So now looking at this on a timeline where day 0 is when your case had onset, or if they didn't have symptoms when their positive test collection date was. The 14 days prior to onset is, again, their possible exposure period, because the incubation period is the 2 to 14 days. So if a school is notified about a COVID-19 case, they need to calculate the infectious period and make sure that the case, if they're still at school, they need to be sent home and be isolated and stay in isolation until the duration of isolation based on your 3 criteria are done. So just to go over some examples, case 1 is someone who tested positive. They had fever, cough, and runny nose with onset on December 1st. Their fever resolved by day 5, which would be December 6th. Their cough and runny nose were improving by day 7, which was December 8th. And so you're infectious from 2 days prior to onset through day 10. And the way we calculate this is we look at those 3 criteria. So it has to be 24 hours after or 1 day after the fever resolves. So that makes makes December 7th, 10 days after onset, which is December 11th. And then their symptoms have to be improving. So that was December 8th. So we take the longest of these, and ends up being the 10 days after the onset, which was December 11th. So that's the last day of their infectious period and the last day of their isolation. So they can leave isolation on December 12th. So their infectious period is 2 days prior to onset. So November 29th is 2 days prior to December 1st and goes all the way through that day 10, so through December 11th, and they can leave isolation on December 12th. So case 2 tested positive again. This one was asymptomatic, and they were tested because mom was positive. So we don't have any fever or symptoms to worry about. They're infectious from 2 days prior to the specimen collection until 10 days after the test date. So that's until December 11th. So their last infectious day is December 11th, and their last day of isolation is December 11th, and they can leave isolation December 12th. Their infectious period started 2 days prior to test date, so November 29th, and went through December 11th. They can leave isolation December 12th. So let's go back to our timeline again. We have our day 0. School's notified. They calculate the infectious period and make sure that the case is sent home already and stays in isolation, doesn't come back until that duration of isolation is over. But then we also need to identify those school-related contacts while the case was at school while infectious. So by close contacts, what we mean is someone who was within 6 feet of an infected person for a cumulative total of 15 minutes or more over a 24-hour period while the case was infectious. So initially, we were just doing 15 minutes and consecutive 15 minutes within 6 feet for a consecutive 15 minutes, but there was a study that showed that some people got infected by being around someone for short periods of time every time, but the cumulative amount was 15 minutes during the day, and they still got infected even though each individual time period was only a couple minutes. And so that's why this changed to be cumulative 15 minutes in a 24-hour period. So close contact also includes people who had unprotected direct contact with infectious secretions. So if a case coughs and sneezes all over someone else and their mucus and secretions get on them, it doesn't have to be a full 15 minutes that they're coughing and sneezing on this person. That other person will be a close contact, even if it's just a couple minutes if they've gotten the infectious secretions on them. So for our contact investigation, we identify all close contacts during the case's infectious period. So for symptomatic cases, we start 2 days before symptom onset, and we continue the contact investigation until the case goes into isolation or until the criteria for discontinuation of isolation is met. So for schools, they need to do the contact investigation from 2 days prior to symptom onset until the last day that the case was on campus during this infectious period or at school-related activity. If the case doesn't have symptoms, you start from 2 days prior to specimen collection of that positive test, and then you do the contact tracing until the last date on campus for schools or at the school-related activity during that infectious period. So now that we've identified those close contacts, they all need to quarantine. We do have a flyer that goes over quarantine instructions, and it's currently under revision to update the time period for quarantine from 14 days to 10 days. So as you may have heard, new guidance came out. So before, everyone was supposed to quarantine for 14 days after the last exposure. But now the guidance says that the safest option is still 14 days after the last exposure. But if a contact is asymptomatic without symptoms, they may discontinue quarantine after 10 days after the last exposure. But they still need to monitor for symptoms and practice strict social distancing, wearing face coverings for that remaining 4 days. So then we still reach that 14 days after exposure with those additional measures. And again, there's a flyer that's pending that should be available soon. So quarantine starts as soon as you know you've been exposed to a COVID-19 case and continues until 10 days after the last exposure to the case while the case was infectious. For school exposures, you count the 10 days from the last day the case was on campus or in that school-associated setting while they were infectious. For home exposures, it's a little more difficult because sometimes the cases and contacts don't separate from each other, especially if there's young children. So the contact would be in quarantine the whole time the case is infectious. So the whole time the case is infectious. And then if they're not separating, the contact has to stay in quarantine until 10 days after the case stopped being infectious. So potentially up to 21 days after the case's onset, that contact would have to be in quarantine. If a contact has a negative test while in quarantine, it does not change the quarantine period. Still have to stay for that 10 days. And then after the 10 days, after the last exposure, when they're let out of quarantine, they still need to monitor for symptoms through 14 days after the last exposure. And if the symptoms develop, they'll need to self-isolate and get tested. So here's some examples of the quarantine period for contacts. So contact A is a household contact. They were exposed since they're in the household from the beginning in the infectious period, which if you recall, since the onset of the case was December 1st, infectious period starts November 29th. And then they continued to be exposed until the case went and self-isolated in their bedroom on day 7. So on December 8th, that's when the last date of contact to the case was, so the last exposure. So they need to quarantine for 10 days after the last exposure, so through December 18th, and then they can come out of quarantine December 19th. The other contact was a close friend who hung out with the case on day 1 of illness. So remember, symptom onset's day 0. Day 1 of illness would be December 2nd. So that was the last exposure. So then the contact B has to quarantine for 10 days after the last exposure, so through December 12th, and can come out of quarantine on December 13th. So the last thing I want to talk about is immunity. So a lot of people have questions about if you can be reinfected or if you've already had COVID, if you have to quarantine again. So really, we don't know how long-term immunity lasts after infection, after being infected. We do know that people who are infected with COVID-19 do have antibody responses, but it's not sure how protective it is and how long the antibody lasts. With other coronaviruses, I mentioned to you that people can get infected over and over again. So with these coronaviruses that cause the common cold, they do cause an antibody response, and you may temporarily have some immunity, but then the immunity wanes and you could be reinfected with those viruses causing the common cold, generally after about 90 days. So a person using the same time period of what we know about coronaviruses in general, a person who has had COVID-19 in the past 3 months or 90 days does not have to quarantine again if they're exposed to another case during this time period. However, if they do develop symptoms again, they should self-isolate and have their illness evaluated. So we have seen very rarely reinfection when a person who had COVID before was sick, got better, later gets infected again. Because it's not clear whether the antibodies are protective and how long the immunity lasts, we don't use antibody tests to determine whether someone is immune or whether they've been reinfected. And then for people who are recovering from COVID or who have just recovered from COVID within the past 3 months, we don't recommend retesting them because the viral test can still be positive if there's still the genetic material there. So really only they should get retested if new symptoms develop and there's no other alternate diagnosis. So that's all I have for you about COVID-19. Here are some resources. Our HCA website has a lot of flyers and fact sheets about COVID. The CDC website, of course, has all the guidance and frequently asked questions. And then the CDPH website has also a lot of guidance specifically for schools in California. In addition, if you have specific questions about cases at the school or need support for complex situations and outbreaks, our HCA COVID Safe Schools OC program is available by phone or by email. And then if you do have questions about this presentation, you can go ahead and contact me. And with that, I'm going to be ending this recording, but remember, we do have another session that does focus more on the COVID-19 case and contact investigation within the school. So thank you again for attending, and I'll be talking to you soon.